Hello friends, welcome to today's lecture on question banks. We'll do question banks from UWorld. So let's start. In this case, a 26-year-old woman comes to the office for follow-up. She has a history of immune thrombocytopenia that failed to improve with glucocorticoid therapy. The patient underwent splenectomy 6 months ago, which resulted in improved platelet counts. She received recommended vaccinations after the surgery and currently feels well. Physical examination shows no abnormalities. A peripheral blood smear reveals many RBCs of a specific morphology as indicated by the arrow below. An increase in which of the following features best explains the presence of these abnormal cells? Pause the video and think of the answer. The arrow in this case indicates target cells, which are red blood cells with a dark center, a surrounding halo of pallor, and a dark peripheral ring. They form in erythrocytes with an excessive surface area to volume ratio, which results in redundant erythrocyte cell membrane folding upon itself, thereby creating the appearance of a target. Target Target cells occur in patients with the following. For a mnemonic to remember the presence of target cells is HALT, where the H stands for HBC hemoglobin, A stands for asplenia, L stands for liver diseases, and T stands for thalassemias. Reduced erythrocyte cell volume from deficient hemoglobin synthesis, for example in cases of thalassemias and iron deficiency, or structural mutations to hemoglobin, example sickle cell, all leads to target cells. Even the excessive erythrocyte cellular membrane due to greater cholesterol to phospholipid ratios can lead to target cell, as seen in case of obstructive liver disease or splenectomy. Macrophages in the red pulp of the spleen remove excess membrane from red cells, a process called splenic conditioning. Patients who undergo splenectomy are unable to prune erythrocytes and generally develop target cells a few weeks following the procedure. However, over time macrophages in non-splenic tissue, example liver, take up the task of pruning erythrocytes, which typically eliminates or diminishes the presence of target cells in the circulation. Thus, the answer to this question is increase surface area to or excessive surface area to volume ratio explains the presence of the target cells. The other options are incorrect, as in choice A, the Pappenheimer bodies are aggregated iron deposits in erythrocytes that are often seen in patients with sideroblastic anemia. They appear as dark blue inclusions. Here there are target cells and no such inclusions. So choice A is not the correct answer. In the choice B, the Howell-Jolly bodies are clusters of DNA remnants, which is seen in erythrocytes due to hyposplenism or asplenism. The spleen usually removes the DNA remnants. They appear as peripheral, round, dark blue or red inclusions in the RBCs. Since there are no such inclusions, the choice B is also incorrect. Then the choice C tells us about the Heinz bodies, which are the aggregates of denatured hemoglobin that may be present in erythrocytes when patients have G6PD deficiency or thalassemia. They cannot be seen on routine staining. Thus, this answer is also not correct. For seeing denatured hemoglobin or Heinz bodies, there is use of spatial staining, that is crystal violet. In choice D, the spherocytes have low surface area to volume ratio and are more susceptible to osmotic stress. They are seen most commonly in hemolytic anemia and hereditary spherocytosis and appear as dense, round red blood cells. Target cells are less susceptible to osmotic stress than normal red blood cells or spherocytes due to their excessive membrane, and therefore the choice D is also not appropriate. In choice E, The basophilic stippling is blue granules dispersed within the cytosol of erythrocytes due to precipitated ribosomes. It is seen most commonly in thalassemias, alcohol abuse, and lead-heavy metal poisonings. Since there are no such basophilic stippling seen in the peripheral blood smear here, the choice E is also incorrect. In this case, a 28-year-old woman comes to the emergency department with acute onset abdominal pain, nausea, and confusion. She has no significant past medical history and does not use tobacco or alcohol as they have made her feel sick in the past. Serum lipase and liver function tests are within normal limits. CT scan of the abdomen shows no abnormalities. A sample of her urine is reddish in color and darkens on standing for 24 hours. Intravenous dextrose is administered and her symptoms improve significantly. Dextrose infusion improved this patient's condition by affecting which of the following pathway? Pause the video and think of the answer. This patient most likely has acute intermittent porphyria, an autosomal dominant disorder of the heme synthesis pathway caused by profobilinogen or PBG deaminase deficiency. In general, enzyme deficiencies in the early steps of porphyrin synthesis cause neurovisceral symptoms, that is in cases of acute porphyrias, but the deficiencies in the latter steps, like after condensation of PBG to HMB, that results in photosensitivity reactions, that is known as cutaneous porphyrias. Acute intermittent porphyria is an acute porphyria that causes nervous system dysfunction due to accumulation of early heme pathway intermediates like PBG and delta aminolevulinic acid. It presents acutely with variable gastrointestinal and neurologic symptoms, most commonly abdominal pain, vomiting, peripheral neuropathy, and neuropsychiatric derangements. A key feature of acute porphyrias is a reddish urine that darkens on exposure to light and air due to oxidation of excess PBG. Treatment and prevention of acute porphyria attacks is directed at inhibiting ALA synthesis, the rate-limiting enzymes of heme synthesis, to reduce formation of the toxic intermediate metabolites. ALA synthetase is upregulated by CYP450 inducers. Example, most of the anti-epileptics, glycofulvin or rifampin, and downregulated by heme and glucose. As such, avoidance of alcohol, smoking, and other CYP450 inducing drugs is important for preventing acute attacks. Likewise, intravenous heme administration and carbohydrate loading, such as with dextrose infusion, are useful for decreasing the acute symptoms. Thus, the answer to this question is porphyrin synthesis. The other choices, like the choices of A, B, C, E, and F, including says that the administration of intravenous dextrose inhibits peroxisome proliferator activated receptor gamma, a transcription factor that induces synthesis of ALA synthetase. This improves the symptoms of acute intermittent porphyria by reducing the overall activity of the porphyrin synthetase pathway, and thus they all are not the answer. This slide shows the reactions involved in heme synthesis. The first and the foremost enzyme, rate-limiting enzyme, is ALA synthetase that converts the succinyl-CoA and glycine into delta aminolevulinic acid or ALA. Then the ALA dehydratase further converts it into PBG or profobilinogen. It then converts it into HMB or hydroxymethylbilane. Then, with the help of uroporphyrinogen 3 synthetase, it converts it into uroporphyrinogen 3. And with the help of decarboxylase, it gets converted into coproporphyrinogen 3. And with the help of coproporphyrinogen oxidase, it gets converted into protoporphyrinogen 9. And then into protoporphyrin 9, which then, with the help of ferrochelatase enzyme, it binds with iron to form heme. Now the glucose inhibits this allosynthetase, thereby preventing the formation of porphyrin, and therefore can help in the cases of acute intermittent porphyria. All the enzyme deficiencies prior to the condensation of PBG to HMB leads to neurovisceral symptoms leading to acute porphyrias, whereas after the condensation of PBG to HMB, the other enzymes deficiencies lead to cutaneous porphyria. And the acute intermittent porphyria is manifested by abdominal pain, neurological manifestations, no photosensitivity as I told you, and port wine colored urine, and PBG and align urine, and this is mostly due to PBG deaminase enzyme deficiency. This picture demonstrates the acute intermittent porphyria urine findings. And this is the normal urine, this is the porphyria urine, and this is after 24-hour exposure to light and air. In this case, a 48-year-old woman comes to the office due to muscle weakness. Her symptoms have progressively worsened since they began 3 months ago. The patient has difficulty with activities such as climbing stairs, getting up from a chair, and placing dishes in overhead cabinets. She also reports a 4.5 kg of weight loss, subjective fevers, and occasional abdominal discomfort over the same interval. Past medical history is notable for gastroesophageal reflux disease and hypothyroidism, for which she takes appropriate medicines. Physical examination shows weakness of the shoulder and hip girdle muscles. Other examination findings are shown in the image below. Further evaluation is most likely to reveal which of the following conditions in this patient. Pause the video and think of the answer. This patient presents with dermatomyositis. It is a systemic autoimmune disease characterized by proximal muscle weakness resembling polymyositis, but with additional inflammatory features involving the skin. Specific skin findings include the heliotrope rash in the periorbital area and chicks, along with Gauthrin's papules, which are raised erythematous plaques over the joints and bony prominences of the hands, as seen in this patient. So these are the Gauthrin's papules as seen in this patient, and the muscle biopsy is diagnostic and shows mononuclear perimysial infiltrates, perifascicular atrophy, and patchy necrosis. Dermatomyositis may occur alone or as a paraneoplastic syndrome, often underlying malignancy. The most commonly associated cancers include ovarian, lung, colorectal, and non-Hodgkin lymphoma. Symptoms may precede the diagnosis of malignancy but often parallel the course of the cancer. Thus, the most appropriate answer to this question is ovarian adenocarcinoma. Here, one point is to be noted that whenever there is condition of weight loss, and if you don't know the clinical presentation of the patient, then from the options you can see there is only one case of malignancy here. So malignancy is appropriate for any kind of weight loss. Questions where there is extreme weight loss. For example, here it is given 4.5 kg of weight loss. Mostly it is seen in cases of malignancies. The other options are inappropriate, as porphyria cutanea tarda is characterized by skin fragility and a blistering rash in sun-exposed areas, and the muscle symptoms are not typical. Therefore, B is not appropriate. Primary biliary cirrhosis is an autoimmune disease of the liver that often is found incidentally in asymptomatic patients. Potential symptoms are typically due to cholestasis and include malabsorption, pruritus, and jaundice, which is not seen in this patient, and hence it is not appropriate. Next, the Whipple infection, Trophyema Whipple infection, also known as Whipple disease, typically presents with arthritis, diarrhea, and fever. Patients may develop hyperpigmentation, but otherwise skin and muscle symptoms are not prominent. Hence, it is not the answer. The type 2 diabetes is due to insulin resistance, which may also cause acanthosis nigricans, a condition characterized by patchy brownish discoloration affecting the neck and skin folds. But since it is not the condition here, it is not appropriate. Now this slide presents to you the Heliotrope rash that is found in the periorbital area and cheeks, and it is one of the clinical feature or clinical finding in cases of dermatomyositis. In this case, a 23-year-old Italian-American man comes to the clinic for a follow-up visit. He was found to have mild anemia during a routine checkup 3 weeks ago and was started on iron supplementation. He has been taking the supplements as prescribed. The patient has otherwise been well. He feels that his energy levels are normal and he has run several half marathons in the last 2 years. The patient's initial hemoglobin levels was 12.3 gram per deciliter. Laboratory test results obtained during today's visit are as follows. Hemoglobin is 12.2 gram per deciliter. Erythrocyte count is 5.8 million per mm cube. MCV is 70 FL. Leukocytes is 6500 per mm cube. Platelets is 180,000 per mm cube. And hemoglobin A2 levels is 6%. The patient's blood smear is shown in the image below. Which of the following processes is the initial step in the pathogenesis of the patient's disorder? Stop the video and think of the answer. Now, this patient has a microcytic anemia as his mean corpuscular volume was less than 80 FL, and also there is increased hemoglobin A2 concentration, and his peripheral blood smear shows hypochromia and poikilocytosis, including spherocytes as well as target cells. So there we can, here in the blood smear we can see target cells and spherocytes. This constellation of findings in an asymptomatic adult of Mediterranean heritage suggests beta thalassemia minor. Beta thalassemia is the most common thalassemia in patients of Mediterranean descent. Alpha thalassemia is more common in individuals from Southeast Asia. The microcytic anemia is often incorrectly attributed to iron deficiency, but iron supplements do not benefit these patients as they are not iron deficient. Normal adult hemoglobin, that is hemoglobin A, contains 2 alpha chains and 2 beta chains, that is it is alpha 2 beta 2 in combination with heme. Beta thalassemia affects beta chain production and can be caused by a variety of DNA mutations affecting the transcription, processing and translation of beta globin mRNA. Most commonly, these mutations cause aberrant precursor mRNA splicing or premature chain termination during mRNA translation. In some cases, point mutations prevent RNA polymerase from binding to the promoter region. The resulting beta globin deficiency occurs in the setting of normal heme and alpha chain synthesis, leading to increased formation of hemoglobin A2 and hemoglobin F, which is alpha 2 gamma 2, whereas hemoglobin A2 is alpha 2 and delta 2. Thus, the answer to this question is mRNA formation. The other options are incorrect because in choices A and G, decreased beta synthesis in beta thalassemia results in the formation of insoluble alpha chain tetramers that precipitate within red blood cells. This can affect the membrane cytoskeleton and reduce membrane stability. However, the initial pathogenic abnormality in beta thalassemia is a deficiency in beta chain synthesis, and therefore the answer A and G is not appropriate. In choice B, in patients with thalassemia, the DNA replicates normally despite the mutation in the beta globin gene, It is not until the DNA is transcribed into mRNA that hemoglobin production becomes abnormal. Anemias due to DNA synthesis defect include the megaloblastic anemias, that is vitamin B12 or folic acid deficiency, which are characterized by an elevated MCV of greater than 100 FL. So this is also not the appropriate answer. Heme is an iron containing porphyrin that is incorporated into globin proteins to form hemoglobin. Globin synthesis, not heme synthesis, is abnormal in thalassemia syndromes. So porphyras are disorder of heme synthesis, and thus it is also not appropriate. Impaired intracellular oxidant detoxification occurs with G6PD deficiency or glucose 6-phosphate dehydrogenase deficiency, which is a cause of hemolytic anemia. Whereas the uh, protein folding is an example of protein folding defect is that it is caused by the Z mutation in the gene coding for alpha 1 antitrypsin. A 5-year-old boy is brought to the emergency department due to 2 days of dark, low volume urine and decreased energy. The parent says that the boy had abdominal pain, fever, and bloody diarrhea for 4 days, which resolved about 3 days ago without treatment. The day before the onset of symptoms, the patient swam in a lake and ate hamburgers at a family picnic. Her vital signs are within normal limits. Physical examination shows pallor but is otherwise normal. He has no peripheral edema or rashes. Laboratory studies shows anemia, thrombocytopenia, and elevated blood urea nitrogen and serum creatinine. Which of the following findings is most likely to be seen in this patient? Pause the video and think of the answer. This patient has hemolytic uremic syndrome, which is often caused by infection with Shiga toxin producing organisms such as Escherichia coli O157H7 or Shigella dysenteriae. Shiga toxin or verotoxin enters the circulation from the bowel and induces capillary endothelial damage, resulting in platelet activation with the formation of microthrombi. Platelet consumption cause thrombocytopenia, whereas the microthrombi lead to erythrocyte damage, forming schistocytes, and the resultant hemolytic anemia, leading to pallor, weakness, and tachycardia. Damage to glomerular endothelial cells also causes acute kidney injury, leading to oliguria or anuria and increased creatinine in approximately 50% of cases. The hemolytic anemia in HUS or hemolytic uremic syndrome causes decreased haptoglobin and hemoglobin level as well as increased serum lactate dehydrogenase and unconjugated bilirubin levels. Therefore, the answer to this question will be B, that is the elevated serum indirect bilirubin. There will be decreased haptoglobin levels in such cases, so the answer A is not appropriate. The bleeding time may also be increased due to the reduced number of platelets. However, other coagulation studies are normal as there are no clotting factor deficiencies or DIC associated with hemolytic uremic syndrome, and therefore the choices C and D is also not appropriate. The Coombs test or the direct antiglobulin test detects autoantibodies against RBCs if they are present in the serum. The hemolytic anemia of hemolytic uremic syndrome is mechanical rather than autoimmune. Therefore, the Coombs test is negative. Streptozyme testing detects antibodies against group A streptococcus and can be used to retrospectively diagnose streptococci infection. Example when evaluating for post-streptococcal glomerulonephritis. However, children with post-streptococcal glomerulonephritis have edema and hypertension but no hemolytic anemia. Therefore, the option F is also not suitable. Now this slide is the summary of hemolytic uremic syndrome, where the etiology is caused due to Shiga toxin producing bacteria, mainly the Escherichia coli O157H7 strain. This is very important. Please do remember this. And Shigella. Next is clinical features, which is antecedent diarrheal illness. Often it is bloody. Also hemolytic anemia with schistocytes, and next is thrombocytopenia with acute kidney injury. This is the peripheral blood smear showing schistocytes that is formed in cases of hemolytic uremic syndrome. These schistocytes are basically the helmet cells that are formed due to mechanical damage to RBCs. A 54-year-old man is evaluated for a 1-month history of worsening fatigue and low back pain exacerbated by movement. He has no prior medical history and takes no medication. Vital signs are normal. Physical examination shows mucosal pallor and bony tenderness. Radiographs reveal lytic bone lesions. Laboratory studies show that hemoglobin is 8.8 gram per deciliter. Serum creatinine is 3.0 gram per deciliter and serum calcium is 10.8 gram per deciliter. Urine dipstick is negative for protein, but quantitative measurement revealed elevated 24-hour urinary protein excretion. Urine electrophoresis is mostly likely to detect which of the following. Pause the video and think of the answer. So the key findings here, that is the lytic bone lesions, and also there is elevated 24-hour urinary protein excretion. All this indicate that this is the case of multiple myeloma. It is a lymphoproliferative malignancy characterized by monoclonal plasma cell proliferation and production of monoclonal paraproteins, example immunoglobulins or chain fragments. Multiple myeloma should be suspected in elderly patients who have any combination of osteolytic lesions, hypercalcemia, anemia, or acute kidney injury, all such which is indicated in this patient. Other common symptoms include weight loss, constipation due to hypercalcemia, fatigue, and recurrent infection. Kidney disease in multiple myeloma is largely due to light chain cast nephropathy, that is myeloma kidney. Intact immunoglobulins, example IgA, IgG, IgM, are too large to pass through the glomerulus, but a small amount of free light chain, example kappa and lambda, are freely filtered and reabsorbed in the proximal tubules. However, in multiple myeloma, the excessive quantities of free light chains exceed the resorptive capacity of the kidney. The filtered light chains then combined with TAM horsefall proteins to form obstructive cast that cause tubular rupture and kidney injury. Monoclonal paraproteins are not detected by urine dipstick, which detects only albumin, but quantitative protein concentrations, spot or 24-hour turbidimetric assay will be elevated. Urine protein electrophoresis, immunofixation, or free light chain immunoassays can be used for diagnosis. Thus, the answer for this question is lambda light chains. The other choices A, B, C and D is not the appropriate, because the multiple myeloma can occasionally cause monoclonal immunoglobulin deposition disease, in which intact immunoglobulins or heavy and or light chain deposit on the kidney basement membranes can be there, resulting in glomerular disease and nephrotic syndrome. In this case, large intact immunoglobulins and heavy chains can enter the urine. However, albumin, which also pass through the injured glomerulus, would be detected on urine dipstick. And since there is no urine dipstick test finding for albumin, so this A, B, C and D will not be the answer. This is all for today. Thanks for watching. If you like this video, please do subscribe and share.